Mhm. If you were to think of what safeguards might be useful when it comes to de-escalating, do you have any thoughts on what could work?
I think, patients that clear their ctDNA have good responses on imaging. Those are things that we could be thinking about. Could we either reduce the dose of enfortumab? Could we be thinking about switching to a different regimen to prolong that sustained response? We had results talking about the durable response that patients that respond have. So patients that have a clinical sorry, I'm going to repeat that. So we had an update from EV302 this past weekend on a subgroup analysis of patients that had a complete response, and 75% of those patients still were in CR at 2 years. And then for patients that had any response, about half still had a response at 2 years. So we know that patients have durable responses, but could we be thinking about different agents to switch out? Could we be thinking about different agents to switch out the enfortumab as far as keeping that durable response? Could we be thinking about different agents that wouldn't cause neuropathy? Or could we just drop the enfortumab and keep the immunotherapy on?
Hmm. When it comes to talking to patients about these potential pitfalls, we talked a little about toxicity, neuropathy, and potentially new therapies. I mean, we're probably a while from getting approved for a applicability. I mean, FDA approval. I feel like I hear that a lot. There's a lot of promising things on the horizon. How do you talk to patients about complications, and then maybe cover a little bit about how you talk to patients about things like clinical trials?
Absolutely. So I think, whenever we think about starting these regimens, and in the case of enfortumab and pembrolizumab, it is the standard of care for patients that are cisplatin eligible or ineligible. We do talk about that, half of patients can have neuropathy, half of patients can have skin toxicity. There's a rare toxicity of ocular toxicity, high blood sugars, things like that are important for us to counsel patients so that they can tell us when they have any onset of these side effects so that we can manage them appropriately. So there are a lot of supportive medicines that we can give to make those side effects better. And we can also reduce the dose of the treatment as well to make those side effects better. I think as far as clinical trials, this is really important that patients, have equitable access to clinical trials. And so I think we talk to patients and, say, you're going to have either the standard of care or something better in the case of a phase 3 trial. Can we be thinking about, the next phase of improving the outcomes for your disease? So, I think really the only way to advance the outcomes is to enroll patients in clinical trials and to keep doing research that is meaningful to our patients. So I think having trials where we believe in both the control arm and the intervention arm, and counseling patients and offering those trials and making sure that they have equitable access to these trials is really, really important. So, we have a wide variety of trials where I work, and whenever we have a patient that could be eligible for a potential trial, we discuss it, and we have to eliminate some of the misconceptions around clinical trials or the fears around clinical trials, and educate patients on, the benefits of trials and how this is the future in terms of improving outcomes for patients with this disease.
Yeah.